This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
This is Katie Krulisky from the University of Utah in Salt Lake City. Today I'm talking with Rosemary Dray-Spira. Rosemary is the Deputy Director of EpiFAR, Senior Researcher at INSERM. We will be discussing her recent paper published in the Neurology Journal titled Trends in Prenatal Exposure to Antiseizure Medications Over the Past Decade. Welcome, Rosemary, and thank you for joining us.
Thank you.
Rosemary, good information and data is so hard to find for guidance within this population and so needed. Thank you for your contribution. To get right into it, what recent trends did you find in prenatal exposure to anti-seizure medications?
We use national data in France. So this data, they cover the whole population in France, and all pregnancies occurred since 2013. And among pregnancy occurred between 2013 and 2021, we found that the number of pregnancies exposed to valproate markedly decreased over time. The number of pregnancies with at least one delivery of valproate decreased by more than 80% during this period. And among pregnancies exposed to valproate, those exposed to multiple deliveries of valproate decreased also, and the number of exposed pregnancies who were terminated increased. So altogether, this means that prenatal exposure to valproate at the national level markedly decreased. And this decrease was mainly in favor of treatments that are considered the safest during pregnancy, that is lamotrigine and levetiracetam, which use increased during pregnancy. They increased by something like 40% during that period. So that's good news, but less good news because during the same period, exposure to other treatments for which prenatal exposure exposed to uncertain or acknowledged risks for the baby. First, exposure to two treatments for which some risks are acknowledged for the baby, carbamazepine and topiramate. For pregnancies exposed to carbamazepine and topiramate, their number decreased over the period, but much less markedly than for valproate. And during the most recent period, there was still about 600 births of children prenatally exposed to this treatment. There needs to be additional measures to limit prenatal exposure to these two treatments because carbamazepine and topiramate exposed to increased risks of malformations and neurodevelopmental disorders.
So overall, it looks like very reassuring in that the group that we know has definitive risks, the valproate specifically, we're not using it as much in this group. And so we're having reduction in prenatal exposures. But with that group of exposures to uncertain risks, such as the carbamazepine and Topamax, are those statistics looking at women on these medications for all reasons?
Our aim was to measure exposure during pregnancy to these treatments regardless of indication. From other studies, we know that these treatments, and from clinical data, we know that these treatments used only for epilepsy, but our aim to measure exposure regardless of the indication. And carbamazepine is mostly used for epilepsy, but topiramate is often used for migraine, but still, regardless, independently of the indication for which the mother takes this treatment, the effect of the medication on the baby is still the same. So this really makes sense to study all pregnancies regardless of the indication.
Completely. I agree with you. My practice is about 50% epilepsy patients, 50% general patients. So I use these medications for facial pain, and then I'm also using it for epilepsy in different situations. And it can be very challenging to navigate with this group because you start off strong and you start them on levetiracetam, and then they have an intolerable side effect. And then you're like, no worries, we'll transition to the lamotrigine. And then they get a rash. And then you're stuck in this situation where you're weighing the risks and benefits of starting these other medications. And so in your paper, I noticed that you included oxcarbazepine within the uncertain risk category. So reviewing the most recent information that has become available from mostly the Epilepsy 2025 Continuum that was released, oxcarbazepine was actually noted as a medication that had a more favorable side effect profile within this group. So is there any local method that you have to capture the outcomes in groups using medications with the uncertain risk category?
I agree with you. When you look at all the available data on oxcarbazepine are quite reassuring. However, these data are still limited, especially in comparison with lamotrigine and levetiracetam, for which the amount of data available on their safety during pregnancy is much more important than for oxcarbazepine. And that's the reason why we categorized this treatment as a treatment with uncertain risk, because at least here in France, we consider that available data is not sufficient at this time to ensure that this treatment doesn't carry any risk for the baby.
That's a really good point, Rosemary. So I'm currently in my last trimester of pregnancy, and I think that is a very challenging point of pregnancy in general. And then specifically looking at these groups with migraines or epilepsy that require some kind of treatment in order to have a high quality of life, is that there is not a lot of information available for this group. So something that I've leaned on locally is that we have a North American Antiepileptic Drug Pregnancy Registry that is a way of collecting information of the pregnancy outcomes on people that are using these medications of uncertain risk. And so in doing so, we're collecting a local data pool where no other information existed before. And I found this helpful. Certainly, it is a group and a collection of information that is needed to be explored a lot more.
I agree with that.
Were there any social differences linked with the exposure of patients to anti-seizure medications with uncertain or acknowledged risks?
Yes, indeed. We found that women who were exposed to treatment with uncertain or acknowledged risk during pregnancy, they were much more often socially disadvantaged than those exposed to lamotrigine or levetiracetam, which much more look like women who don't use antiepileptics during pregnancy. So the question is, why these social differences in the use of this treatment during pregnancy? And there are several hypotheses which may explain these differences. The first one is that they don't benefit from the same quality of care, who are more disadvantaged from a socioeconomic point of view, may have a lower level of care. And another point is that they don't have the time to adapt their treatment before pregnancy. And so that's an important message of the paper, that actions and measures should be taken to make these women, and especially those who are the most socially economically disadvantaged, to make them adapt their treatment before the start of pregnancy.
It's something where you have to, as the doctor they're seeing, you have to be really proactive about it, because not everyone is meticulous about planning their pregnancies. So whenever I'm starting a medication in people of childbearing years that is part of our first discussion before starting any medications is, could you become pregnant? Because even if you're not necessarily planning to, if you are participating in sexual practices that could result in the pregnancy, then in my book, you are trying to become pregnant, and we need to choose medications based on that practice.
Yeah, completely.
Another important medication that was highlighted in your paper that falls within the uncertain risk category is the gabapentin and pregabalin. What were your observations on use of these medications within the prenatal exposure group?
Yes, another important result of our study was that besides the relatively low evolution of the number of pregnancies exposed to carbamazepine and topiramate, we showed that pregnancies exposed to other treatments, and especially treatments for which the risk is uncertain, these kinds of pregnancies, they increased during the study period. Especially, we show a very marked increase in the number of pregnancies exposed to pregabalin and gabapentin, which are most often used for the treatment of pain, but still, they are antiepileptics and they are used for epilepsy too. And the number of exposed pregnancies for these two treatments increased very markedly in France in the recent years. And I think that's also the case in many countries. These treatments, there has been some studies showing they are associated with increased risk of birth defects, and even some studies suggesting increased risk of neurodevelopmental disorders in the exposed children. So they should be used with caution during pregnancy, and this hasn't been the case in the recent years. And also there has been increases in the use of more recent antiepileptics, included lacosamide and zonisamide, which are used at a lower level, a lower frequency during pregnancy, but still at an increasing rate. And for these treatments, which are quite recent compared to those we talked about before, strictly no data on the safety of this treatment during pregnancy, and so they should be used with a lot of precautions during pregnancy.
That's a really good point. Gabapentin is something in Lyrica that is used a lot more than it used to be for a lot of different treatments that cross over into the field of neurology and outside of it. So that is one that could easily slip through recognition if we're not being more cautious to look out for it. And then the zonisamide and lacosamide, that is another one because they are great seizure medications. So, you know, the information that is available, which is not a lot, has been promising, but there's a lot more information that's going to become knowledge within the years to come. And that art of medicine is always an uncomfortable position. The best we can do is just having an open and honest conversation with our patients. So it's helpful to have researchers like you that are continuing to further the information available within these areas and best practices.
There are some antiseizure medications which has shown to be safe, so they should really be prioritized for pregnant women.
Completely agree. If only every pregnant woman or woman of childbearing years tolerated lamotrigine, that would make things much easier.
Yeah, I completely understand that it's very challenging in the management of these women, but the risks for the baby are so important that it's really worth it.
And the other thing that's worth mentioning within this podcast is making sure that your patients are on prenatal vitamins and have the correct amount of supplementation with folic acid. That's another important and easy thing to implement. And that should be started at least 3 months before pregnancy in ideal situations. It always surprises me how people are not aware of that.
Exactly. And maintain this treatment during the whole pregnancy too.
Thank you again, Rosemary, for taking the time to discuss your work looking at prenatal exposures to anti-seizure medications. The paper is titled Trends in Prenatal Exposure to Anti-Seizure Medications Over the Past Decade, and you can read all the details in the Neurology Journal.
Thank you very much.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.